Listen, everybody wants to jump straight to the stethoscope. Nobody wants to ask questions. But NCLEX absolutely loves subjective assessment. Imagine your patient says, "I'm short of breath." Okay, that tells us almost nothing. When did it start? What makes it worse? What makes it better? Do you cough? Do you wheeze? Do you have chest pain? Does it wake you up at night? Do you smoke? Have you ever been diagnosed with asthma? The answers to those questions can completely change your clinical thinking. Now let's talk sputum, because NCLEX loves sputum. Clear or white sputum? Often viral. Yellow or green? Think infection. Rust-colored sputum? Tuberculosis should pop into your head. Pink frothy sputum? That should immediately make you think pulmonary edema. And that is one of those clues that practically gives away the answer. Okay, friends, now we're finally getting to the point where we can actually look at the patient. And here's the thing. Inspection is free. No stethoscope, no equipment, no fancy skills, just your eyes. And honestly, some of the most important respiratory findings can be spotted before you ever touch the patient. When I walk into a room, I'm immediately looking at how fast are they breathing? How hard are they breathing? Do they look comfortable? Or do they look like they're fighting for every breath? Because those are two very different situations. One of the biggest things we're looking for is increased work of breathing. And this is where nursing school starts giving us clues. Accessory muscle use, nasal flaring, retractions, tripod positioning. All of these findings tell us the same thing. Breathing has become work, and breathing should not be work. Let's talk about tripod positioning, because NCLEX absolutely loves tripod positioning. If a patient is leaning forward, hands on their knees, trying to catch their breath, they're not getting comfortable. They're trying to breathe. Tripod positioning helps open the diaphragm and allows the lungs to expand more effectively. When I see tripod positioning, my brain immediately goes, something respiratory is happening. Now add accessory muscle use. You start seeing muscles in the neck helping with breathing. You see shoulders lifting. You see effort. That's a red flag, because breathing should happen automatically. The second the body starts recruiting extra muscles, it means we're struggling. Okay, friends, quick question. A nurse enters a patient's room and notices the patient sitting forward with hands on their knees while breathing rapidly. Which assessment finding is most concerning? A. Symmetrical chest expansion. B. Respiratory rate of 18. C. Tripod positioning. D. Vesicular breath sounds. Pause here. The answer is C. Tripod positioning, because it indicates increased work of breathing and possible respiratory distress. And honestly, if I see tripod positioning, I'm paying attention before I ever grab my stethoscope. Now let's talk respiratory rates, because students get these mixed up all the time. Tachypnea, bradypnea, hyperventilation, apnea. And they all sound similar enough to make your brain angry. So here's how I remember them. Tachypnea, fast, shallow. Think tiny quick breaths. Hyperventilation, fast, deep. The word hyper makes me think extra. Extra breathing, extra depth. Bradypnea, slow breathing. Apnea, no breathing. And that's generally a bad life choice. This is one of those areas where NCLEX likes to test whether you understand the difference. Because fast does not always mean deep, and deep does not always mean fast. Make sure you're separating those concepts. Now let's look at the shape of the chest, because sometimes the body gives us clues before we ever listen to lung sounds. Normally, the chest is wider side to side than it is front to back. We call this the AP diameter, anterior to posterior diameter. Normally, it's about 1 to 2. Now enter COPD. Years of air trapping can cause something called barrel chest. Instead of a normal ratio, the chest starts looking closer to 1 to 1. Think of an overinflated balloon. Air gets trapped. The lungs stay expanded. The chest changes shape. And suddenly we have one of the classic findings associated with chronic lung disease. You might also hear about kyphosis and scoliosis. And here's why they matter. Anything that changes the shape of the chest can potentially affect breathing. Now let's talk about something students sometimes overlook. Not everybody breathes the same. Kids are different. Pregnant patients are different. Older adults are different. Let's start with infants. Babies breathe faster than adults. That's normal. Secondhand smoke increases the risk of asthma, respiratory infections, ear infections, and even sudden infant death syndrome. Now let's talk about older adults. As we age, the lungs lose elasticity. Gas exchange becomes less efficient. A nurse is assessing an older adult patient. Which age-related change should the nurse expect? A. Increased lung elasticity. B. Increased chest wall expansion. C. Decreased respiratory reserve. D. Larger alveolar surface area. Pause here. The answer is C. Decreased respiratory reserve. Older adults have less ability to compensate when respiratory problems occur. And that's why respiratory assessment becomes even more important in this population.